Hi, everybody. We'll start in about 2 minutes. Okay, good evening and welcome to tonight's webinar on understanding male fertility. So in the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. My name is Maddie. I will be your host for this evening. I'm an IVF nurse at our Clayton clinic. I've been a part of the team here at Clayton since May 2023. Prior to joining Monash IVF, I was working in emergency. My interest has always been in fertility and reproductive health, so it's been a great transition for me. I love the continuity of care we get as IVF nurses, and it is a privilege to be that main point of contact for patients during their treatment. It's very special being able to build relationships and support our patients throughout all stages in their fertility journey, and it's what makes my role so meaningful. So at Monash, we are committed to empowering the next generation of parents on their journey to parenthood. We are here for people at all stages of their fertility journey, proud to support patients of all genders and sexualities on their pathway to parenthood. The entire Monash IVF team are incredibly passionate about the care and support we provide our patients. So our locations, Monash IVF provide world-leading scientific and medical services. We have clinics all across Australia in Victoria, New South Wales and Queensland, and sister clinics in the Northern Territory, South Australia and Western Australia. Here are the services that we offer. We offer comprehensive reproductive care. We provide everything from fertility testing through to IVF, IUI, and ICSI. And of course, we can support a variety of donor treatment options as well. So the agenda for this evening's webinar, first we have Dr. Alon Talmor, who will discuss male factor infertility, followed by Dr. Kani on lifestyle impacts. Lastly, Dr. Tal Jacobson will cover fertility investigations and treatments. And then we'll wrap up at the end with a Q&A with all the presenters. Our specialists will be sticking around at the end of the presentation to answer your questions. So please submit your questions for the Q&A using the Q&A button at the bottom of your screen if you have any questions throughout the presentation. We will do our best to answer your questions, but we might not get to them all. It's important to us that you get the information that you need. So if your question isn't answered, we do offer complimentary phone chats with my team of experienced fertility nurses. The nurse inquiry team can provide you with advice about what your next steps could be and can answer any questions you may have about fertility or fertility treatment. You can scan this QR code to book a complimentary nurse chat. My team can also help you book an appointment with one of our doctors if you wish. So whilst we do our best to be affirming, we just wanted to flag that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We're proud to support patients of all genders and sexualities. Everyone is welcome in our clinics. The information provided in this webinar is general in nature and does not replace personalised advice from medical professionals. Our first presenter this evening will be Dr Alon Talmor, who is based in Victoria. Dr Talmor is a UK-trained specialist in reproductive medicine with a PhD in molecular biology, focusing on male fertility. Known for his thorough, compassionate approach, Dr Talmor specialises in complex fertility cases, including male infertility and PCOS. In this session, he'll give an overview on male factor infertility and discuss the elements of fertility that are unique to men. Dr Kashani Kanangara, our second presenter, will be Dr Kashani, who is based in New South Wales. Dr Kanangara is a reproductive endocrinologist and fertility specialist with over 13 years of experience. She has a deep understanding of the endocrine system, and in this session, she will focus on lifestyle factors that influence male infertility, offering insights into proactive measures to support reproductive health. Our final presenter this evening will be Dr. Tal Jacobson, who is based in Queensland. Dr. Jacobson is an experienced fertility and obstetric specialist committed to providing individualised care across all stages of family planning. Dr. Jacobson is a skilled specialist practitioner and an accomplished academic with a career that has taken him around the world. In this session, Dr. Jacobson will guide us through essential fertility investigations and explore various treatment options to address infertility and concerns effectively. I would now like to hand over to Dr. Alon Talmor for our first presentation of the evening. Welcome, Alon, and thank you so much for joining us.
Yes. Thank you so much, Maddie. Can you hear me? Fantastic. Today I'll be talking about male factor infertility, and it's a great pleasure to welcome you all tonight. I hope you find this series of talks helpful, and as Maddie said, we'll be delighted to answer any questions you might have later on after the talk. Thank you. So as an overview, we know that 1 in 6 couples in Australia might have some struggles with infertility. That's quite extraordinary. And the number of, if you break it down into the causes of infertility, well, 30% of infertile couples might have a male factor that might predominate and cause an issue that might need to be addressed. 30% potentially is a female factor. The other 30% might be a combination of both male and female. And in 10% of couples is idiopathic. We don't actually know why couples cannot fall pregnant. But the important thing is it's not always a case. If we don't know why a couple can't conceive, it doesn't mean that we can't treat people successfully to start a family. So it's all good, and we can deal with all those aspects very, very thoroughly. Thank you. If you look at the chances of conception on a monthly basis, looking at various semen parameters, you can see on the graph, if the semen parameters are very low concentration, the chance of falling pregnant on the left-hand side of that graph is exceedingly low. But as the semen concentration increases, you can see that the chances also increases. So by the time someone has a semen analysis of, say, about 50 million or 40 million sperm per mil, it can be actually a lot lower, then the graph plateaus, which means the chances of conceiving should be just under 20% per month of trying. Thank you. And on this next slide, that is another way of kind of reaffirming what we just said. Obviously, if you look at the orange line right at the bottom, if a man has no sperm, then the chance of conception is going to be pretty much 0. And as his concentration does increase, so for example, if the semen concentration is between 1 and 5 million sperm per mil, well, there should be about a 30% chance of a couple conceiving with those sort of parameters. But as those numbers increase, you can see in the second red line and then in the green line, those chances are increased. So if there's no female cause of infertility, but the male factor is looked at, you can see that if a couple try and conceive for about a year with a normal semen analysis, they should have a very, very high chance of falling pregnant within a couple of years. Normal statistic that we quote is about 85% should conceive within 1 year, and then over 50% of those who haven't should conceive after the second year of trying. So if you look at what factors influence fertility, well, these factors are both related to the person who's the egg provider, the sperm provider, and also the person who's carrying the pregnancy. So looking at various parameters, the most sensitive predictor for women is age as it happens, but also you're looking both in terms of genetic causes, because sometimes genetics can, of course, affect fertility. And the idea of doing robust genetic testing is to see whether or not, well, to find out if there's any reasons as to why fertility might be affected. But also when thinking about the next generation, if there's any genetic issues there, then we can also be clever in terms of screening out any genetic issues that might ensue in the subsequent generation. Obviously, lifestyle modifications and choices play a very pivotal part in what we do. And obviously addressing various fertility conditions is something that we would normally do really very comprehensively to see what can be done to augment that, to maximize your chances of falling pregnant. Now, there's stark differences between male versus female causes of infertility. We know that with a male, on the left-hand panel, you can see on the screen, there's a gradual decrease of parameters with age. Normal concentration and morphology tends to decrease once a man is over the age of 40. The motility of the sperm is also decreased with age, and seminal volume will also potentially decrease with age. We also know that for a man after the age of 55, less Y chromosome-bearing sperm are produced for some reason. Having said that, if you look on the right-hand side of this slide, looking at the female causes of fertility, we know that the chances of conceiving should be about 25% when a woman is in her 20s. But then there's a gradual decrease and decline in fertility until the age of about 35 to 37. Now, these are rough numbers and rough guides of ages, and everyone kind of behaves differently at different stages as well. But we know that after the average age of 37, there tends to be quite a precipitous drop in fertility. We know that about 50% of women can be classified as infertile at about 40. And virtually all women by the age of 45, nearly 46, virtually all of them are infertile. And of course, you're all going to read about women who do fall pregnant at that sort of age. And of course, they can do, but it becomes exceedingly difficult. The role of genetics plays a big part in the decrease quality and numbers of eggs. But the most important point that I'd like to push ahead with this slide is if you're thinking of starting a family, then age should be at the forefront of your mind. Because obviously if someone is in the mid-30s, well, there should be a decent chance of falling pregnant with the first child, hopefully. But if you need to sometimes think strategically, well, how many babies ideally would you want to have? And if it's 2 or 3, then you need to think, well, there's a time lag between trying for each baby. A pregnancy, as we know, is virtually a year, and then most people would not want to think about having another baby for another year or 2 after the first one is born. And so bearing in mind that with age, there is a decrease in fertility, then thinking, as I said, strategically is something that is probably not a bad thing to do. The next slide, please. So why does it change with age? Well, we know that men generally produce about 100 sperm per day, and that's an ongoing production line of sperm. However, over a 12-month period for men over 40 years old, they have 30% lower chances of a pregnancy. So age does play a part in fertility with men as well. But you also need to adjust that with female parameters. So if a woman has very high fertility parameters, well, that might compensate for slightly lower male factor issues. We know that with increasing age, there's high degrees of DNA fragmentation. And what I mean by that is when a sperm has half the number of chromosomes as the rest of the cells in our body might have, so eggs and sperm have half the number of chromosomes, and when they come together, they make 46 chromosomes. But it's the DNA that can get fragmented with increasing age and therefore decreased chances of pregnancy. But as you know, there's no absolute age cessation of sperm production with men in most cases. But if you look at the female population, we know that that is not the case. And there's a very defined number of eggs that are made, and then they're gradually lost with age. So by the time an embryo fetus is 20 weeks in gestation, there's probably about 67 million eggs in those developing ovaries. A few months later, when the baby is born, there's only 1 or 2 million eggs left. So it's a huge drop of the egg numbers, even from the time the baby is in the womb, by the time that female baby is born. And then at puberty, at the age of 12 or so, there's only about 300,000 to 500,000 eggs in the ovaries. So just to clarify, that's not 300 eggs, that's 300,000 to 500,000 eggs left in the ovaries. And we know with every cycle, there's an egg being released. So over a woman's reproductive life, about 400 or 500 eggs are lost through ovulation. But it's important to know that every month there's a whole cohort of eggs that get recruited into the ovaries, from the ovaries, to start developing. Only one will dominate, and that will be released at ovulation. But the other pool of eggs will also die at that month. That's called atresia. And that continues virtually till menopause ensues, when the eggs supply, the bank has now all ceased. And that's when a lady goes through menopause. Now, it's important to remember that the average age of menopause is 51 to 52-ish in Australia. But it's not to say that a woman can fall pregnant until 51, because if you remember the slide that we spoke about that previously, is the chance of falling pregnant is virtually zero by the age of 45, 46-ish. So there's a lag between the time of a woman might still have regular periods, but it might be very difficult to fall pregnant between that time and the menopause. Obviously, the different factors can affect age of menopause, and that's something that's important to remember as well. If there's a family history, for example, of early menopause, and there can be a whole variety of reasons as to why that might be the case, and that's something that we look at a lot, then we might want to think about thinking of strategically how we'd think about fertility options at an earlier stage. Thank you. So there's various different types of male infertility, and that's when men come to see us. It's important for us to know how to classify those causes of infertility, because then there's treatment choices that will be tailored accordingly to the causes. So essentially, we break down male infertility into two big blocks. One of them is obstructive. That means there's some obstruction that stops the sperm from traveling through and being released, or non-obstructive. And non-obstructive means there's some inherent testicular issue that is involved or is affecting sperm production. Relative infertility or subfertility, again, that's something we see quite a lot. Again, it's classified as oligozoospermia, so decreased numbers of sperm. And it's important to know that if you do have a test that shows slightly lower number of sperm, I wouldn't jump into any conclusions very quickly, because these numbers tend to fluctuate for a whole variety of reasons. And it's probably worthwhile obviously seeing an expert, a specialist, but also repeating a semen analysis as well. There could be an issue associated with the motility of the sperm, or immunological issues where sperm can sometimes be clumped up together with antibodies, and therefore they cannot travel up and meet the eggs and result in fertilization. So what are the causes of male infertility? Well, there can be spermatogenic failure. That means spermatogenesis, the process of making sperm, might be hindered for a variety of reasons. So sometimes we just don't know why that happens, and that's what we term medically idiopathic. We don't know why sperm production has stopped. There could be genetic factors, such as Klinefelter syndrome. It could be Y chromosome deletions. That means the Y chromosome that makes men specifically men. There could be regions on that chromosome that might be deleted, and it's those genes on the Y chromosome that are very heavily involved in sperm production. Now, it's important to establish and ascertain if that is the case for a variety of reasons, because sometimes semen analysis can be very low because of some of these Y chromosome microdeletions or deletions. But also, if we then help couples to fall pregnant, we want to see what's going on, because some of these conditions might be carried on to a male baby. That's not an issue, but it's important to have an idea of those so that we can capture fertility later on once that baby comes into adulthood as well, potentially. There can be other causes of spermatogenic failure. There could be wrong number of chromosomes, so aneuploidy, or single gene conditions might affect that. Testicular damage is something that we also sometimes see that might result in infertility. Very importantly, cancer treatment is another cause. So men who've previously had cancer, by receiving various treatments for that can affect fertility. So some chemotherapy agents might affect things as well. Other conditions, including cryptorganism, that is when the testes have not descended as they should properly. Sometimes it could be vascular issues or infective issues, or trauma that we mentioned as well, might result in issues with fertility. Gonadotrophin deficiency, you have to understand that the process of making sperm is very much mediated by different parts of the brain that releases hormones that then talk back to the testes to produce sperm. And if there's a disruption, what we call the hypothalamic pituitary gonadal, so the testes axis, then that can have some issues with that. And there's a whole variety of reasons as to why that might be the case. Now, if we look at the other part with obstructive causes of infertility, well, vasectomy is one of the most common reasons that I might see in my practice as to why that is an issue. So gentlemen who might have had a previous vasectomy, clearly the tubes have been disrupted, so the sperm physically cannot travel down to be released. Sometimes we see something called congenital absence of the vas deferens, and those are the tubes that lead out of the testes. And in some conditions, such as cystic fibrosis, then there can be absence of those tubes. So the important thing is, normally people will know if they have cystic fibrosis, but sometimes they can have really worse presentations of that, though they're not aware. And that's why it's important to make sure that we examine a man if there is a testicular issue, and also we can potentially come with a diagnosis. And the other idea of that is to do a full genetic screen so we can establish if there's a risk of a baby being affected by that. And then there's other obstructive disorders that might result in that. The other cause of male infertility might be erectile or ejaculatory issues. And that can be lots of reasons for erectile dysfunction, and there's lots of stuff that we can do to address that. Ejaculatory issues, that can be due to, for example, spinal cord injury. And so I would have seen lots of men that have had that, and generally there's fantastic ways of addressing that and having success. And I've got a wonderful family who've had 3 children with the male partner having spinal cord injuries. Sometimes some men have what we call retrograde ejaculation. That is when they do ejaculate, but the sperm gets ejaculated into the bladder. And in that case, it's quite simple to then do a urine analysis after that, extracting the sperm in an appropriate way, and then moving forward with fertility in that sense. And some men just do not release any sperm with an ejaculation. Thank you. So fertility conditions impacting sperm. Well, we know that there are low rates of sperm production. Sometimes we see men that have absent sperm, and the medical term of men who do not produce sperm is azoospermia. Can be associated with genetic abnormalities, so it's important to establish what those are, as I've explained earlier. Blocked vas deferens or other tubes is important to understand. And we know that sometimes those blockages can be present from birth. That means it's a congenital cause, or as a result of surgery, which is what we spoke about earlier, for example, vasectomy, or due to some severe trauma or infections that might affect things. We also need to think about other conditions that can be diagnosed by us when you seek more specialized help. So what are the impacts of age on sperm? Well, we know that sperm quality does decrease with age. The risk of miscarriages is higher if the sperm provider is over 45 years, but that's not to say that if you're over 45 years, then you should not consider fertility treatment. Absolutely not. There's lots that we can do, but it's something that is important to just bear in mind. Diseases are more common in infertile men, and that's a really, really important slide. Sometimes a man might present with infertility, but underlying that might have things like testicular cancer. And that's quite a poignant thing to remember. I remember having a gentleman present to me, so I work in Melbourne, who came from the border with New South Wales because he had a very low sperm count. And I remember thinking, well, why to come all the way to Melbourne for that? But it was what it was. And so, of course, if that is the case, if there's a low sperm count, it's really important that gentleman might be examined. In this case, I did examine the gentleman, and immediately I could feel something that didn't feel quite right. And the advantage of being in a big clinic was I phoned up the radiology department. They scanned him within 40 minutes, looked like testicular cancer. I called one of my urology friends, saw him the same day, and he was operated and cured by the end of that week. So it's fantastic, but it's really important to remember not to ignore things, see a specialist, and then if there's anything that might be serious, well, that can be dealt with, and then concentrate on the fertility journey from there. We know that about 10% of men who have fertility issues might have testosterone deficiency. And that's important because replacement therapy is something that can have huge benefits and lifelong implications for a man. But the important thing to remember for the gentlemen here that are listening to this talk is, for God's sake, do not start testosterone before fertility concerns are addressed. Because what happens is, once a man starts testosterone, that tells that what we spoke about earlier, that pituitary axis to stop the hormones that will encourage sperm to be produced. And so by taking testosterone, sperm production is stopped, and sometimes it can be for a very long time indeed. And stopping testosterone can be also really quite challenging in some cases. So don't start testosterone, obviously never without a prescription, but also need to think about fertility implications with that. Thank you. So what are the myths and misconceptions associated with fertility? Sometimes we hear people saying, I've had a child before, so it can't be possibly anything to do with the man. That is, of course, not the case. And why is that? Well, because things can change with age. And as we spoke about, some diseases, some illnesses that might have happened might affect the sperm quality or numbers. And what I tell my patients is actually a semen analysis result is a really sensitive barometer to a man's health, and therefore must never be ignored. And if the numbers are looking a little bit on the low side, well, it's really incumbent on the doctor to try and find out, well, why is this the case? Is there something else going on? Because if I do find something else, I can address that, well, hopefully those parameters can be improved. Another misconception is I have a problem. It means I am sterile and will never be able to conceive. Absolutely not, okay? So we have a whole team of people and doctors and very specialized clinicians who are here to help people. And even if there's no sperm, in the vast majority of cases, there's something that we can do to help a couple. If I have a problem, there's nothing that can be done about it. Well, going back to what I said previously, absolutely not. There's lots that can be done about it. We engage with other specialists as well. And so there's always something that can be done, virtually most cases. Male fertility problems are rare. It's only me. No. As we said, 30% of the people that we will see in clinic will have a specific male factor. Probably 60%, if not more, will have some male component with it as well. Okay, so the vast majority will have some issues that can be addressed and dealt with. We haven't been really trying, but not using contraception. I hear that quite a lot. And the idea is if people aren't using contraception, the chances are that, pregnancy might have happened eventually at some point if they haven't used contraception, for example, for 10 years. So to say we haven't really been trying, so therefore there's no fertility issues, I take that with a pinch of salt, and maybe it's worthwhile investigating things a bit more from there. We haven't been trying mid-month. Again, it's not always that the ovulation will happen exactly on day 14 of a stylized 28-day cycle, because everyone's different and ovulation timing might be different. And then for men to think, they lack testosterone, and therefore take testosterone, as I said, and that's why repeating this twice, no. It's important for us to check what those testosterone levels are, and also look at the whole context of things with the sperm results as well. So first steps, well, see a doctor. Typically you might see your GP as a starting point if there are fertility concerns. And it doesn't matter if you're male or female, it's obviously important to have both of you assessed if you're coming in as a couple. The GP or the doctor may order a semen test and also take a history. Look at the current problems and past medical histories, because obviously some past medical issues might affect sperm production. Obviously, it's important to assess what the general health is, sexual function, frequency of intercourse, any medications that a man might be taking, because of course sometimes there can be some drug interactions that can affect sperm production. Taking a comprehensive history of drugs and alcohol and smoking is important, because we know that all those things do affect not just the sperm numbers, but quality, etc. If there are concerns, of course, it's probably important to see a specialist that might deal with fertility issues, and that will be normally a gynecologist that has a special interest in fertility, or an andrologist, which is normally an endocrinologist that deals with male factor issues and hormones. So with that, I'd like to thank you so much for having me on today to give you my brief talk. I'm going to hand you over to Kishani for the next presentation. And if you want to book an appointment or learn any more, of course, you can scan the QR code. So thank you so much, and I'll see you at the Q&A session at the end of the talk today. Good night.
Thank you. So I'm going to take over now. My name is Kishani Kananga, and I'm an endocrinologist and andrologist based in New South Wales. So thank you for joining. I'm going to move on to talk about lifestyle and the impact on male fertility. So I really want to stress the idea of healthy habits leading to happy families. Fertility is really an important part of family health. And there are many factors that we can sort of suggest and do, modify, including lifestyle, diet, and environment. So you've got the first slide there about caffeine. So too much of a good thing can be harmful or can have effects. And caffeine and various types of tea do contain caffeine, whereas energy drinks and some soft drinks have a much higher content. And we know that excessive caffeine can affect reproductive health and sperm in terms of, as Dr. Talmor mentioned, numbers and morphology, how they move, and what they look like. Diet. Now, we're always hearing about the benefits of a good diet, but it does have significant impacts on sperm quality and health. So eating a variety of nutritious foods, fresh foods is what we're really wanting to stress. Fruits, vegetables, whole grains, lean proteins really can help maintain a healthy reproductive system and sperm factory. Really reducing the amount of processed takeaway foods that really have lost a lot of their goodness, and that really will promote healthy sperm production. Now, I'm going to talk about weight and its medical implications. Weight and weight gain and even weight loss can have significant effects on sperm. So being overweight or severely overweight can affect your body in a number of different ways. It can affect every organ in your body, actually, your liver, your gallbladder, your vessels in your body. It can increase your risk of things like sleep apnea, cancer, and also psychological impacts as well. But when we're looking at sperm production and fertility, things like high blood pressure and then medications that you need to treat that, abnormal lipid levels as a result of insulin resistance and abnormal liver function can then put you at increased risk of things like insulin resistance and diabetes. So we want to make sure that we can actually get a healthy weight range and focus on regular exercise and, again, eating well. Thank you. So what is the damage that can happen when you have too much weight? An excessive BMI in the obese range leads to an overproduction of adipocyte or fat cells in the body. And there can be consequences across the body, which I mentioned, but there's physical effects on the body, also effects on the sperm production, and then a resultant effect on hormones. So there could be an increased risk of or increased frequency of erectile dysfunction, so maintaining the erection for ejaculation. The physical effect of having too much weight in that groin area or the suprapubic pad can actually increase the temperature that the testes are at. And we know that testes should be outside the body at a lower temperature for optimal sperm production. When you have excess weight, you also have an impact on your hormone levels and testosterone levels, and that can increase the risk of things like obstructive sleep apnea, which also then lowers the testosterone during the day. Having excess weight can impact sperm numbers. So azoospermia means an absence of sperm or a reduction of sperm. It also can increase the damage that can happen within the testes, so fragmentation and also changes to the volume. Long-term effects of increased fat cells can also mean more estrogen. Now, every man has got a little bit of estrogen and more so testosterone, but it can increase the ratio. So then you can have clinical implications of having too much estrogen for men, which can have impacts on the liver, on the weight distribution, and also things like breast tissue development. That leads to a reduction in the overall ratio of testosterone, and as I mentioned, increased insulin resistance, and leading to things like blood pressure issues and diabetes. Next slide. Another thing we're also promoted when you're trying to have a baby is to decrease the alcohol intake. So increased alcohol intake or binge drinking especially is associated with a longer time for a couple to conceive. So alcohol can cause impotence and erectile issues, can also damage the sperm quality that we see. So we really ask our patients to minimize or abstain when they're trying to conceive, and it really will make an impact. So there are supportive networks available and through your GP as well to sort of look at ways in which you can limit alcohol intake during this time. often get asked about vaping and smoking. So we do know that smoking definitely affects sperm morphology, or what they look like, and motility. So smoking and vaping increases DNA damage to the sperm, which can increase the risk of mutations or changes, which can then lead to more frequent occurrence of miscarriage, or impact the health and future of the child. So we do know that stopping is ideal, and reducing the smoking frequency and amount can definitely impact sperm quality. I have definitely recently been involved with a couple that the sperm looks like night and day with just those little changes, and stopping smoking, the morphology, the movement, the number all improved. So it really is something to see under the microscope when you can see these changes and how positive it can be for a couple. Recreational drugs can also have a negative effect on sperm quality and sperm production. Performance-enhancing drugs can also decrease sperm production, and I'll speak to you more about that in a second. And there's a lot of support out there in terms of minimizing drug use. So anabolic steroids, or use and misuse, there are some significant effects of taking testosterone, and Dr. Talmor mentioned this, that it does definitely affect fertility. But if you're misusing it to change your body shape and appearance, there are some significant, potentially long-term consequences of that. It can actually it does shrink the testes, so there's a reduction in testicular size or volume. It can lower or remove sperm production, so the sperm count can be lower or absent completely, contributing to subfertility or infertility. Long-term use can also have quite dire effects on libido and erectile dysfunction. Breast tissue growth, or man boobs, is something that can happen with anabolic steroid use, and then ultimately leads to impaired function of the testes. Now, the testes only has two jobs to do. One is to make testosterone, and the other one is to make sperm. And I think it's really important to be open with your doctor regarding past or current steroid use, because it does have an impact for what we do moving forward in terms of how we can help couples. But it is something that can have significant impacts on conceiving spontaneously. So this is sort of the axis that I'm talking about. So when you do introduce testosterone from outside, it sort of inhibits the natural pathway from the brain to the testes. And there's a signaling process which involves release of hormones from the pituitary. So when you do stop and withdraw, there is a slow sort of offset and then a recovery period. But during that time, there would be symptoms of a low testosterone, also the infertility and the development of breast tissue that can occur because that estrogen component is higher. But to restore that sperm production, it is really important to stop the anabolic steroids at that time, if it was that reason. Also, patients that are on testosterone and want to conceive would have to stop during that time and have recovery of their brain to testes access as well. So just to recap in terms of what the steroids do, they do stop the body's own production of testosterone. It can take your body weeks to months to get back to making its own testosterone and sperm, and that can vary with each person. But it is actually a form of addiction, and there are withdrawal-like symptoms, mood changes, and cravings. So it is important to discuss with your specialist, your doctor, use in the past and things we can do to help moving forward, and monitoring it and keeping it under surveillance as well. As Tal mentioned, there are also environmental factors and medications that can also impact sperm quality. A lot of prescription medications that can have impacts on sperm function. Finasteride syndrome, which is also something related to hair loss that some men might try, may have an impact on sperm function and production long term. We also do promote avoiding exposure to pesticides and chemicals that may affect sperm quality. And in terms of what people do for work, avoiding laptops that heat in your lap, and also work practices that are involved in exposure to high heats, even something like a chef that's around a lot of cooking and high heats, can have an impact on sperm count and motility. So there are other strategies to protect and promote male fertility. One thing that I promote quite a lot is mumps vaccination in childhood, because having mumps at the time of puberty can also cause significant damage to the testes just from the temperature effect. Environmental policies need to be looked at in terms of plastics and their effect on fertility, because we have been shown that many compounds that occur in plastics have negative effects on reproduction in animal studies. So microplastics and endocrine disrupting chemicals, EDCs, that really can interfere with the production and action of these important hormones for male fertility. Now, if you go to your local pharmacy, you will see quite a lot of products available for male and female fertility. And I've just listed some of them here, but green tea, ashwagandha, flaxseed oil, and there is some variable evidence that it may or may not improve. If nothing else, it may cause or produce expensive urine as you detox and get that out of your body. But I think that, again, following a natural diet with unprocessed foods and a healthy mixed diet is the way to go. But there is evidence that some antioxidants and things can actually improve male fertility. So again, promoting fresh food, things like walnuts, oily fish. Zinc has been shown to improve sperm motility. Folic acid and vegetables that contain a higher proportion of that include broccoli, kale. So these are all things that we need to promote for healthy baby-making diets before trying. As I mentioned, there are some supplements that have been found to have positive effects on male fertility and sperm parameters. Zinc, CoQ10, vitamin E have been shown to have some benefit, and a multivitamin can be helpful if your diet is deficient. So of fresh fruit and vegetables, again, your body will take what it needs. But I think we're just trying to promote healthy living, again, for that healthy habit to reflect on sperm function. So just to conclude, having a healthy lifestyle, balanced diet, adequate sleep, managing stress, taking the right supplements and getting tested and examined can improve male fertility. But understanding these lifestyle factors can also affect male fertility. We need to take the steps to improve fertility and make the best recommendations to increase our chances of having a healthy family. So I hope you found that useful, and I will be here for any questions at the end. Thank you. Next is Dr. Jacobson.
Okay, thank you very much to Alon and Kishani and to Maddie for hosting. My name is Tal Jacobson. I'm a gynecologist based in Brisbane, as well as working in fertility. I'm going to talk about fertility investigations and treatments, and really sort of the aim of any GP or fertility specialist that you see will be to try and understand and help you understand your reproductive health before you actually start fertility treatment, because it will very much guide your treatment, and having an understanding of where you're starting helps us decide what sort of plan to come up with to help you conceive in the future. Thank you. So in terms of assessments, what are we trying to achieve? Well, can we actually find something that can be sorted, reversed, managed, improved in the sperm, and particularly in the male partner's health to restore natural fertility and give you the opportunity to conceive spontaneously? Can we actually find a reason at all that we can, again, treat the subfertility, particularly for the male in this situation? Quite often we don't find any reason for abnormal sperm or poor sperm parameters, despite taking a thorough history and various investigations. Are there any other health problems that may be relevant for conceiving or for the health of the future child that can be identified at the assessment process? In particular, are there any genetic conditions? This is usually related to the couple, but we can offer genetic testing that can potentially pick up things that you may not have been aware that you were a carrier of. And again, just looking at the success and safety of assisted reproductive therapy, which is a very broad term, ART, that would cover everything from ovulation induction, intrauterine insemination, IVF, fertility preservation, a very wide gamut of techniques. And the success is very variable. It has a lot of indicators or contributors, including female age, as Alon said, partly to do with male age, and then other things in relation to quality of the eggs, quality of the sperm, any other factors that might be relevant, like uterine factors, etc. Thank you. So a fertility health assessment is something that may well be managed by your GP, or you may have been referred to a fertility specialist to assess this further. And anyone involved in contributing eggs, sperm, or planning on carrying the pregnancy itself needs to have a fertility assessment if they've been having any difficulty conceiving, or if there is a known situation where you're going to need eggs or sperm from a donor or something like that. The results of those investigations will obviously help inform the specific plan for you, and with your understanding, you may be able to change some lifestyle factors, or there may be some specific medical or surgical interventions that are required. Thank you. So essentially, again, your GP or your fertility specialist will involve all members that are involved. So the contributor of the egg, the sperm, and the uterus, and they'll take a general history about your general health, your past medical history, your lifestyle. We've already Kashani's discussed in detail about smoking, drugs, alcohol, exercise, and diet. Your previous fertility history in terms of whether you've had children before, miscarriages, those kind of things, and your medical history, whether there's any contributing conditions, genetic conditions, cardiac conditions, respiratory conditions that may be contributing to either infertility or may affect management of that. The physical examination is important, certainly a general examination, and a testicular examination for the male may be relevant to assess the testes and the penis, and if there's any particular issues or complications that need to be managed. There are some investigations that we'll come on to, and then usually with the information from the history and the relevant investigations, with any fertility assessment, there'll then be a review consultation going through all of those factors to come up with some options that you can proceed ahead to try and conceive. And often those options may have different costs, different timings, and different success rates to help you sort of work out where you want to proceed to. Thank you. So one of the really burgeoning fields in medicine is genetic testing and genetic screening. And basically, genetic carrier screening is to test healthy adults to see if they have an increased chance of having a child with a serious genetic condition prior to conception. So it is possible that you could be perfectly healthy yourself, but you may be a carrier of a gene that could have a significant effect on children. And in particular, we're looking for conditions where both partners may be carriers, they may be perfectly healthy themselves, but if they have one healthy gene and one abnormal gene, if they pass on both the abnormal genes, their child would have the condition. The most common condition that we see that with is cystic fibrosis. About 1 in 20 men are carriers. They have one abnormal and one normal gene, and 1 in 25 women are carriers. And if those two carriers are partners, then their child they have a 1 in 4 chance of passing on the abnormal genes. So their offspring would have 1 in 4 chance of having 2 abnormal genes, which means that that child would have cystic fibrosis. So it can be very useful to have this information beforehand. Our college, RANZCOG, which is the Royal Australasian and New Zealand College of Obstetrics and Gynecology, does recommend that people considering pregnancy undergo screening like this. And the federal government has recently provided funding to make this screening much more accessible to people now. The routine screening that can be performed for most people is cystic fibrosis, a condition called spinal muscular atrophy and Fragile X syndrome. And the cost for that is either $120 or may even in some situations be much less than that. There are screening programs that can look for hundreds of genetic conditions. And in that case, we usually test both partners and then match up to see if they both are carriers of the same condition. There are some genetic conditions that you may already be aware of that run in the family that can be looked for as well. Monash IVF offers a very simple genetic carrier system, a screening system where you can just take a swab, a saliva swab, and send it off. It'll come to you, be delivered to your home, and that can be tested, and you can get the results. If the results are abnormal, it is important to have genetic counseling to discuss the implications for you, your family, your wider family potentially, and for your offspring. Thank you. So we've talked about genetic carrier screening. It's important to understand your immunization status. So things like measles, mumps, rubella, COVID-19, those sort of things, and potentially chickenpox, varicella as well. So those are relatively simple things that we can test prior to starting on the fertility treatment journey. For infectious diseases, we'll usually look for things like hepatitis B, C, and HIV, just to exclude those again. So that if you have those, it doesn't mean you can't be treated. It just means that the lab is aware there may be some changes in the process, but it certainly doesn't prevent any treatment if you were to be positive for those. But again, it's very important to have an understanding of those conditions, because again, there are things that we can do potentially in the lab that would minimize the risk of transmission to any offspring. So knowing about those in advance is important, but certainly doesn't exclude treatment. And then probably most important for deciding on treatment methods is the semen analysis. The semen analysis, male needs to produce the sample, usually with an abstinence period of between 2 and 7 days. So shouldn't ejaculate for at least 2 days, but no more than 7 days abstinence period. And they need to get it to the lab, usually within about 45 minutes of production, in order to get the sort of the best guess of the, or not guess, the best assessment of the semen analysis result. So if we could go on to the next slide, please. So the semen analysis looks at a whole load of different parameters. Usually we try and organize it so the scientist is actually waiting to assess the sperm, and there's a number of processes that need to be gone through. It's usually spun down and various measurements are made. And there's a number of different things that are used. So the total volume is assessed, the total sperm count, which is the total number of sperm that are in there. That is essentially the concentration times the volume. The concentration is the number of sperm per mil. And so if there's 2 mils, you just double that. You can do sperm antibody tests. So sometimes if you've had testicular trauma or infection or reversal of vasectomy, there may be antibodies that can attach to the sperm and prevent them moving as well as we'd like them to. Sperm motility is important. So what proportion of the sperm are moving, and more importantly, what proportion of them are not just wiggling or going around in circles, but actually have a progressive movement sort of in one direction. And then sperm morphology is sort of what the sperm look like under the microscope. And I'll show you a slide where of sort of normal sperm and abnormal sperm. And you don't need too many normal sperm. But it is important to have an understanding of the proportion of normal sperm. Next slide, please. So certainly, again, just understand what is normal. As Alon said, if you provide a sperm sample, once a week for a year, you're going to find huge variations from the same individual in terms of the sperm concentration. And so it's not that abnormal to get most of them above the line, if you like, of normal sperm parameters, but a few will be below the line. So certainly if you have an abnormal semen analysis, don't be too despondent. It's important that you repeat it, and you may find that at repeat it's quite normal, or some of those lifestyle changes that have already been discussed can actually improve the sperm as well. A normal semen analysis doesn't necessarily guarantee that you're going to be able to get pregnant or that everything's normal. The semen analysis, there are some parameters here. I won't go over them in detail, but there's essentially what are called the WHO or World Health Organization parameters. They're used throughout the world as a benchmark to assess whether your sperm is normal or not. And when you have your sperm report and you discuss it either with your GP or your fertility specialist, they'll talk about the volume, the concentration, the motility, the morphology, and any of the other parameters that are relevant. And sometimes there may just be one parameter that's a little bit out. Sometimes everything will be out. And so all of these things are taken into account in discussing where to go from there. Next slide, please. This is just an example of sort of normal sperm versus abnormal sperm. And you can see over on the right-hand side, sperm, or certainly start on the left-hand side, which is essentially a normal sperm. It has a headpiece. That's that sort of teardrop-shaped part. That's where all the DNA is packed in, really wrapped up super tightly into the headpiece. There's the midpiece. The midpiece has got this like the powerhouse to drive the sperm, and then there's the tail itself, which is obviously producing the motility of the sperm. And so those three things are very important to provide functionality to get that sperm to the egg and allow the sperm to get into the egg for fertilization. There are lots of different abnormal sperm, and it's normal to have more abnormal than normal sperm. So again, that the morphology percentages of normal can be as low as 4% or 5% and still be normal. And you can see here, you can get abnormalities in the headpiece with, for example, 2 heads or funny shaped head or extra big or extra small head. The midpiece can be abnormal. And then, of course, the tail, you can have 2 tails or bent tails or non-motile tails, etc. So plenty of defects are possible, and most men will have lots of abnormal sperm, but as long as they have a reasonable number of healthy sperm, that should be okay, and that'll be taken into account. And if there are abnormal sperm, there are ways of getting around that with procedures like ICSI, where the sperm is injected into the egg rather than relying on its motility. Next slide, please. Again, your specialist may examine the testis. There's a sort of a ring of beads called the orchidometer, which has all these different sort of sized testicular-shaped plastic beads, and they're quite useful if you're sort of comparing there and then in front of you the size of a testis, and they can be useful to sort of assess the size. And reduced testicular volume can be associated with poor sperm production, but also it's really important to, we've already mentioned testicular cancer. You can get all sorts of other testicular cysts. You can feel whether the vas deferens is actually present. That's the sperm, the tube that the sperm travel down. So quite a lot can be gathered from an assessment of the genitalia. And the orchidometer is just a small part of that. Next slide, please. So we already talked about some of the treatments for male factor infertility, and for mild male factor, your doctor may recommend some lifestyle changes. We've talked about alcohol, smoking, weight reduction, dietary changes, exercise, etc. There is some evidence for antioxidant vitamins, vitamin C, vitamin E, probably more vitamin E than C. And there are some products on the market that there is some evidence that shows that poor sperm can be improved with this. Another thing I haven't mentioned is that sperm takes around about 3 months to form. So if you have a poor semen analysis and you make a lifestyle change, it may actually be 3 months before that is reflected in the quality of the sperm that you're producing. Likewise, if you're unwell, you've got a really bad flu or something like that, 3 months later, your sperm may actually be poor, reflecting your illness 3 months previously. So this is part of that sort of significant variation in sperm production, depending upon your health at the time and other factors. Obviously, if you can improve the female factor, that may be relevant. So it takes two to tango, and sometimes improved female factors can offset worse male factors. There are some, if the sperm is normal or only mildly affected, then a treatment called intrauterine insemination is perfectly reasonable. Intrauterine insemination is basically taking the sperm and injecting it through the cervix into the uterus itself. So with normal intercourse, the sperm is deposited at the just outside the uterus, at the neck of the womb, the cervix, and many sperm are lost on their journey through the cervix or through the cervical canal into the uterine cavity. They still have to then get into the tubes, find an egg before the embryo comes back and implants. And so that's quite a journey, and that journey can be helped by injecting the sperm through the cervix into the uterus. It's a relatively simple technique, and the sperm needs to be normal or nearly normal to use that technique. IVF is where we collect the eggs and take the sperm and put 500,000 or so sperm around each egg, and usually one of the sperm will get into each egg and fertilize it, and that's certainly can be used for moderate to somewhat severe male factor or poor sperm parameters. But if there's very severe poor sperm, or IVF has been tried and it hasn't worked, then we can certainly consider something like ICSI. ICSI is a procedure where the sperm is taken and a single sperm is injected into the egg itself. And it's highly successful in situations where the sperm is not good enough to allow normal IVF, or you've tried normal IVF previously and you've had fertilization failure or something along those lines. The success rate of any fertility treatment or just conceiving in general is highly dependent on female age, as Alon has already discussed. And so again, all of these things will be taken into account. I haven't specifically mentioned it, but up to now, but of course, there are ways of accessing sperm. If you've had a vasectomy without a reversal, you can do a reversal, or we can do what's called a teaser, where we aspirate sperm from the testis itself, or sometimes a more major procedure where you open the testis and extract sperm that way. So there are other techniques that we can use to access sperm even when it's more complicated. Next slide, please. Next steps, if you are thinking about, if you have any concerns about your fertility, either now or in the future, or want us to just see how you're going, or you've had difficulty conceiving, then we would recommend that you get a referral from your GP to see a fertility specialist. It may depend on your personal situation. You might go alone, you might go with a partner, depending upon what you're looking to achieve. We already discussed the sort of discussion and examination and investigations that will be undertaken. And in many situations, Medicare rebates will be available to help cover the costs, or not cover, but certainly contribute towards the costs of those investigations and treatments. Thank you. I work in Brisbane, in Spring Hill, at a clinic called Eve Health, and it's been a pleasure talking to you this evening. Thank you.
Okay, it's time for the Q&A portion of the evening. We've had a lot of questions that have come through, so we won't have time to answer them all, but we will do our best. Alrighty, so the first question is for Kashani. So my partner isn't unhealthy, but is far less health conscious than I am. He vapes and drinks energy drinks, etc., while I'm big on nutrition and fitness. Will this impact our chances of conceiving dramatically, even with IVF?
Yeah, so I think the issue is, it sounds like this partner's not terribly unhealthy, but I think, anything that you can do around the time of trying for a pregnancy will help. So reducing or stopping vaping, reducing the amount of energy drinks with caffeine in it will definitely help. But until you start trying, you don't actually know. And that's where, it comes down to in terms of the speed in which you take to conceive. So I think the issue is reduction or stopping around the time of trying will definitely enhance your chances of conceiving at the desired time.
Awesome, thank you. Next question is for Alon. So if someone has suffered trauma to their testicle in their 20s, how can they determine if it will impact their fertility in the future, and should they investigate now or wait?
Thank you for that question. Well, trauma can obviously affect sperm production, and as Kishani rightly said, the testis does two things. It's involved in testosterone production and sperm production. So if anything that is possible that might happen that might disrupt this, that's important to note. Normally there'll be warning signs if there are issues with the testes. So for example, if testosterone production is affected, there might be issues that might manifest themselves early on during puberty and so on. But ultimately, the idea is to really test fertility. Well, the most sensitive thing is to do a sperm test and potentially also look at hormone blood levels that your doctor might decide to do to establish if everything is okay. Lots of people that we see, for example, might have had previous testicular cancer, a form of trauma, and a test is removed. Well, the other one can compensate, and there should be no issues at all. So don't worry just because there was a previous injury, and I see lots of patients that do worry about injury that happened when they were in the early teens or whatever. Normally things are okay. So to put your mind at rest, probably worthwhile doing those tests and moving forward from there.
Great advice. So next question is for Tal. So how frequently should men ejaculate for the best quality sperm?
Oh, that's an interesting question. So the WHO criteria, the ones that we use for assessing semen analysis parameters, which are tried to be standardized, have you shouldn't ejaculate for at least 2 days, but it should be a maximum of 7 days before the previous ejaculation. And the aim of that is to give a sort of very standardized semen analysis count. But that is really just to give an assessment of the sperm in order to compare it to other people. You can ejaculate twice a day, 3 times a day without any sort of problem with your fertility. You could ejaculate once a month without any problem with your fertility. But if you actually did the semen analysis on the very frequent ejaculations, you might find a lower sperm concentration. It may not necessarily be relevant for your fertility. So I guess what I'm trying to say is I don't think that I can clearly give you a healthy ejaculation frequency.
Okay, no worries. Alrighty, so next question is for Kashani. How long do men need to stop drinking alcohol before trying for a baby? Good question.
So I suppose, as you mentioned before, in terms of the sperm production, sperm is produced, it takes 3 months. So I suppose in that time would be a good time frame in terms of you thinking about it in the next 2 to 3 months, really trying to reduce the alcohol consumption, and especially things like binge drinking, which has quite negative effects on sperm production. So I would say, as soon as possible, but within the 3 months of trying.
Probably not coming into Christmas. So next is for Alon. Is cycling bad for male fertility?
That's a great question. And obviously, sitting on a saddle for hours on end might potentially have some implications. I don't think there's very strong evidence to suggest that there's increased rates of infertility in men who cycle. Obviously, being fit and healthy probably outweighs anything. So I think generally it is good. But obviously, as I said previously, if there are concerns, get that tested. But I would encourage having a good, healthy lifestyle, and exercise probably outweighs any concerns with cycling. If the saddle, of course, is uncomfortable, you can change one to make it more comfortable, but I wouldn't necessarily stop your exercise, no.
Now, Tal, when you freeze and unfreeze sperm, what percentage of them actually survive?
Another good question. So if the sperm is normal, then a freezing and unfreezing sperm has a very, very high survival rate, probably more than 90%. And usually, if you do freeze sperm, your lab will usually do a test thaw. They'll freeze a whole load of it, and then one of it they'll thaw to get an idea of the percentage survival in your case. But as your sperm quality goes down, your sperm survival rate from the freeze thaw is definitely lower. And so that doesn't mean you shouldn't freeze poor quality sperm, but the percentage may be lower, and you may be more likely to need to resort to techniques like IVF or ICSI that can cope with lower quality sperm. But in general, good quality sperm has a super high freeze thaw success rate or viability survival rate.
It's really good news. So next question is for Kashani. Can you talk a little bit more about testosterone and the stopping of sperm production and the recovery process of the sperm when coming off testosterone?
Yeah, so again, it depends on the duration that you've been on testosterone and how frequently, whether it's for treatment or whether it's whether you're abusing in terms of taking too much too regularly. But what it does is stop your pituitary hormones that are released by the pituitary to signal the testes to make sperm and testosterone. So the brain is smart, but the brain can't differentiate from where the testosterone is coming from. So it thinks there's ample supply of testosterone, and then it turns off that natural access and says, no, we don't need any more production, thank you. It's like turning off the TV with the remote. It's still there, but it's not functioning. So the idea is we need to slowly then get that access to start up again. And so that can take, as I mentioned, sort of weeks to months to fully recover and to have those signals being released and promoting that healthy sperm production and testosterone. So it is a bit variable, but it does improve, and it can recover in most cases.
Thank you. So next question for Alon. What is considered a low sperm count?
So that's a great question. The WHO, the World Health Organization guidelines are that a normal sperm count is 14.9. Let's call it 15 million sperm per mil, okay? But that's not to say, which comes back to what we said earlier, that if someone has a lower sperm count, that they might have difficulties in conceiving. I've had couples when the male sperm count was 500,000 sperm per mil, and they conceived spontaneously with 2 children in one case. And so you have to understand that whilst the parameters of the man is important, the other side of the equation is the fertility on the female part. And if she's super fertile, well, that can compensate for slightly lower sperm count. But generally, 15 million sperm per mil is the number that we look at. And the important thing is, for our perspective, if it's well below that, and everyone has slightly different cutoffs, but I think most of us, if the numbers are below 10 million sperm per mil, well, that might trigger us to want or to warrant to do some further investigations to see if there's any underlying reasons for that to be the case.
Great, thank you. So next question for Tal. Is there a link between abnormal sperm morphology and DNA fragmentation?
DNA fragmentation, so when I mentioned the head of the sperm, it carries half the chromosomes. They're all crumpled up super tight and they're sort of bent up, and the DNA is sort of slightly fragmented because it's packed in so tightly. So DNA fragmentation is a measure of the amount of sort of DNA damage within the head. Now, it's normal to have some DNA damage. It's just the degree of DNA damage that's relevant. So there's different tests, tunnel test, SCASA test, a few others that look at DNA fragmentation. And certainly the more DNA fragmentation you have, the lower your fertility potential, but it's not an absolute thing, as we've discussed already. And the what else was I going to say about that? So, you know, it's normal to have like 15% DNA damage, 15 to 30% is sort of mild, you know, mild damage. 30 and above is getting a bit higher, and certainly above 50% is significant DNA damage. Sorry, I've completely forgotten the first part of the question.
First part of the question, was there a link between abnormal sperm morphology and DNA fragmentation?
Oh, I do not believe so, no.
That's good news. Great. So another question for you, Tal. How about acupuncture? Can it help to increase male fertility?
Ooh, I'm not familiar with any randomized control studies that show that acupuncture improves male fertility. Certainly the ones that have been tried where the acupuncture has been offered to the female have not been shown to be beneficial. I don't know if there are any studies I'm certainly not aware of that have shown it to be beneficial in male. Having said that, things like acupuncture people enjoy, they feel relaxed, no problem doing it whatsoever. There's certainly no evidence to do any harm. It's unclear at this stage that it is beneficial.
We do find that acupuncture is very popular with our patient population. They love it.
Not saying don't do
it. Perfect. So for you, Kashani, besides lifestyle changes and taking vitamins, how else can you increase motility and morphology?
Yeah, so I think it is the lifestyle, exercise, diet, it does have a big impact. And I do think actually intimacy and being active in that way actually will help sperm function and testosterone levels in men as well. So we know that having intimacy and having intercourse is going to actually affect your hormone levels as well, and that will also help with libido and trying more often. So I think those are sort of the tried and tested ways that might help.
Beautiful. Now, this is one for the floor. Bit funny. Why is there no contraceptive pill for men yet? Does anybody know why?
They have tried. I was involved with the WHO study that was when I was in Melbourne, and we tried to give men injections to try and work as a contraception, but there was one pregnancy, I have to say, that slipped through, but it was an injectable form, and so a bit inconvenient to have. But yeah, I think it's a great question, and we're still waiting, I think is my understanding.
No worries. So I think we've got one more question. What have we got here? So, do contact sports put you at a higher risk for testicular injury, and can this impact the ability to conceive? For anyone to answer.
Well, contact sports, if I might just start off. Obviously, if they are associated with injuries, then of course that's going to affect things. And so it's important to conduct those obviously in the safest possible way and understand how they can affect things. So yes, they can affect things, but it is not that common to result in devastating things. I very rarely, when I used to do my urology jobs, and men used to come in with torsions, not that often after sports injuries. So they do happen, but it's not that often.
You can keep playing your footy and your rugby and you'll be okay.
And be fit, exactly.
Yeah. Excellent. Well, that's all we have time for, I'm afraid. Thank you guys so much for being here this evening and answering everyone's questions and presenting. For everyone listening, I'm very sorry we couldn't get to all of your questions tonight. But please scan the QR code to book a complimentary nurse chat with one of our experienced fertility nurses for personalised guidance about your options. So thank you all for attending. I wish you all the very best on your fertility journey. Thank you so much, guys.
Bye-bye.
Bye.
Yeah, thanks so much.
Bye.